Hello and welcome, dear audience. At this episode, I will discuss certain issues regarding the treatment of physical and sexual abuse of adults. So, I'll start with initial evaluation, as many victims of assault initially present to the medical doctors for the treatment of their injuries. And in the emergency departments, patients may often be treated for their injuries without the assault being recognized or addressed. So, it's important to consider any injury as being a potential indicator for an assault. The patient may initially be also avoidant when asked about the causes of their injuries. And this issue may also be complicated by the need to do certain tasks. For example, the photo documentation, as well as the medical legal reporting. So, it's of paramount importance to build a rapport with the patient while continuing to complete a thorough evaluation. And it's also important to reduce the victim's stress and anxiety regarding discussion of the event, as the crime may represent a time when the patient lacked control, and similar feelings in the initial interview can lead to a triggering of traumatic or anxiety responses. So, the physician should remain attuned to the nonverbal patient responses that signify discomfort and conduct the interview accordingly. Patient, when they disclose domestic violence, this should be documented in their charts for further follow-up and possible medical legal documentation. Then, the safety issues. So, after the assault, it's imperative that a safety assessment be performed on the victim. The patient needs to be evaluated for suicidal and homicidal ideation, as it pertains to the recent assault. Patient safety from further assault also need to be addressed, especially in a setting in which the perpetrator was a loved one or a known person. The patient also need to be screened for severe psychological symptoms that would cause difficulty in self-care. These may include acute mood deterioration or affective instability, the self-destructive behaviors, the dissociative symptoms, or psychosis. So, a plan should be made for the patient's physical safety, and the patient should be given a place to sleep and to eat. Then, sometimes we discuss the issue of hospitalization. And in the event that the patient's safety cannot be guaranteed, hospitalization for the assault victim may be a necessity. Common indications for hospitalization may include severe medical injuries, suicidal or homicidal ideations, dissociative or psychotic symptoms, mood instability or affective dysregulation, the self-destructive behaviors, and a continued serious threat to the patient's life or well-being. So, if the victim is admitted to the hospital and the decision is made to admit the patient, an individualized multidisciplinary treatment plan should be developed, where the safety, the milieu therapy, the mood stabilization, and medication evaluation are the primary treatment modalities provided in the hospital and reflect the short-stay nature of most psychiatric facilities. And because the assault victim will likely need longer treatment than what can be provided in the hospital, it's important that there is a coordinated inpatient to outpatient transition, which psychiatric, medical, as well as social work issues all being addressed prior to discharge. We also need to focus on the legal issues, as a physician evaluating an assault victim needs to adhere to the mandatory reporting requirements for the place in which he or she is practicing. So, mandatory reporting of cases of child abuse, abuse of developmentally disabled children, and abuse of the elderly exist almost all over the world. Also, in cases and setting of injuries secondary to domestic violence, this can sometimes be considered a de facto mandatory reporting situation. The focus also should be made on psychotherapy treatment, as after the patient's safety has been ensured, the initial evaluation is complete, there is a variety of psychological interventions that can be initiated. For example, the cognitive behavioral approach, which are the most researched techniques that demonstrated efficacy in such cases. The exposure therapy, which is a variant of the cognitive behavioral therapy, has also been shown to help victims emotionally process the assault by decreasing their fear to memories or cues of the event. There is also evidence in the literature that brief early cognitive behavioral therapy may also accelerate recovery in victims manifesting acute post-traumatic stress disorder. The so-called eye movement desensitization and reprocessing, the EMDR, is also another alternative treatment for the processing of distressing memories. These individual psychotherapies may also be augmented with group psychotherapy, art therapy, dance therapy, movement therapy, and body-oriented approaches if they prove beneficial to the patient. The question of psychopharmacological treatment should also be considered because medication is not recommended in the acute treatment of assault victims, but it may be beneficial in certain circumstances. The clinician may decide to medicate a patient with distressing anxiety, extreme aggression toward themselves or others, or dissociation or psychosis immediately after the assault. So the patient's safety and safety of those around the patient will help to decide the need for pharmacological interventions. Most medication treatment will be initiated much later after the assault as the patient develops symptoms of post-traumatic stress disorder, depression and anxiety, or obsessive-compulsive disorders, or even psychosis. Although medication may be useful in symptoms management, they should not be viewed as a replacement for psychotherapy. Thank you for having me in and hope to be in contact with you soon.